Thank you so much, chairpersons. Very good afternoon, invited guests, respected Chancellor and Vice Chancellor and Principal of Al Karim University, the seniors sitting in front row. I feel very humbled when I have to give a talk on all things fibrous. I'll try to confine myself in this thing. Like, I would not try to divulge from the topic. Wherever I feel something is important to be told to our junior colleague, I would just take advantage of few seconds to share my experience. My topic is approach to diagnosis of fibroblastic and fibrohistiocytic tumors. Though I have written it as minimalist's approach, uh, I would welcome you to disagree from me for a certain point of time when I would also discuss certain recent IHCs and molecular changes in these tumors, because when all these senior faculty sitting here and the senior colleagues of mine would definitely agree that when we are looking at the soft tissue tumors, we have a great plethora of overlapping morphological features, and that's the region. uh, I would also congratulate Dr. Rajesh Kumar, who has been a very good friend of mine for more than a decade. I think it's been around 2 decades now. Rajesh has been working with me since my post-graduation days, and he's always been so dynamic. Thank you, Dr. Rajesh, for inviting me here and having me here to talk upon this topic. Uh, in the recent WHO classification, the consensus group thought that we need to revisit the tumors, because if we remember our old days, many of these tumors, if you remember, like nodular fasciitis or like inflammatory myofibroblastic tumor, these were grouped under reactive lesions or non-neoplastic lesions, if I remember my training days. But these many changes happened after repeated meetings of the clinicians and these soft tissue pathologists. And with further molecular analysis, they found that these are not really really reactive or non-neoplastic lesions. They have the common molecular alterations, proving it to be the clonal lesions. And once we all know that once we have a clonal lesion, they are no more reactive, even if for a transient period. And why I say this transient would be shown in the forthcoming slides. My agenda of the talk would be to talk about certain recent changes in the fibroblastic lesions / tumors, because I write that with purpose. And I would be talking about certain morphological patterns, the IHCs, the current molecular changes in the diagnosis of these soft tissue tumors. And I would like to emphasize and would like to invite the interest of the audience sitting behind, because my purpose is to tell you and probably help you delineate these soft tissue tumors. आप एक बार स्लाइड देखते हो, आपके पास सॉफ्ट टिश्यू ट्यूमर लग रहा है, तो हम क्या करें? मेरा पर्पस ये है, एंड फॉर दैट I would try to share my own experience as well as the experience of the legendary pathologist of this field. This is the recent the fifth edition of the WHO classification, in which you can see there has been addition of many new tumors. The nomenclature had changed. For example, if we take a look at the EWSR1 SMAD3 positive fibroblastic tumor, which is still emerging. We are still working on this and trying to know what is the biological behavior of these tumors. Superficial CD34 positive fibroblastic tumor on the right side, and the earlier fibrohistiocytic tumors. आपने सुना होगा सब fibrohistiocytic tumor. Now they have been called as so-called fibrohistiocytic. So why did WHO feels like naming these odd entities, so-called fibrohistiocytic tumor? And this has been already included in the recent WHO. So-called, there has been reasons for this, and that's why it was all the tumors were revisited by the WHO sitting group. Some of the major changes that has been incorporated in the fibroblastic and myofibroblastic tumors are like mammary type myofibroblastoma. If you remember the earlier edition of the WHO, the mammary type word has been removed because the fibroblastomas earlier, whenever they were diagnosed, it was felt that, okay, this lesion is commonly found in the breast. Now they told that there are certain lesions, I would talk about them, mammary type fibroblastoma, elastofibroma, and a couple of tumors like angiofibroma. If I ask my pathology colleague, they will remember that angiofibroma was classically known as nasopharyngeal angiofibroma, or we knew that all these angiofibromas are occurring in the nasal and paranasal cavities. But it's not so. So they were separately grouped here कि ऐसा नहीं है कि सिर्फ nasopharyngeal angiofibroma होता है, हमारे पास एक separate entity है soft tissue tumor का, which is called as CD34 positive fibroblastic tumor or soft tissue angiofibroma. With that, I would like to highlight, as our respected senior Dr. Asitava Mandal sir has been always emphasizing, that soft tissue tumor diagnosis relies on large extent on the radiological findings, on the clinical findings, and so the approach goes like this. You must have the clinico-radiological details of the lesion. You should try to define or differentiate between these lesions, like whether they are reactive, whether they are neoplastic, and little bit of background knowledge is required to be sure that these are not neoplastic, which you are going to label it as neoplastic or reactive, whatever, based on certain factors. What are those factors which will tell you it is not reactive, it is neoplastic? So again emphasizing, you should know the molecular changes within these tumors, and if possible, you should try to get the changes detected by different methods. Once you have defined that this is a neoplastic lesion, you have to try to classify them based on the available guidelines, especially the WHO classification of the tumors. You should also consider the morphological overlapping tumors, the differentials that needs to be separated out with the help of various ancillary techniques, particularly IHC. My dear colleagues, my dear PG students, I must reiterate here that IHC is no more an ancillary technique. With histopathology, IHC I think is like bread with I would not call butter, because we are not so practiced of having roti with or bread with butter always. I can tell that it is bread with sabji or bread with dal. So it's very mandatory to have certain selective IHCs at least. So the ancillary techniques will tell you in two ways it will help. It will differentiate the mimics, and it will prove your lesion to be what you are thinking of. So this way you will reach the diagnosis, and then you must remember that it's great to have ancillary techniques, but morphology only will tell you. If you don't think of a fibrosarcoma, or if you don't think of a solitary fibrous tumor, you would probably put some other marker. So the morphology only tells what kind of IHCs, what type of IHCs are to be applied and to differentiate these tumors. And for that matter, because once you start approaching soft tissue tumors, you will have 2-3 morphological findings, which I will also discuss in the coming slides, that the soft tissue tumor may give you an appearance of purely spindle cells. It may also present to you as an epithelioid cell. It may also give you an appearance of a small blue cell. So all these are soft tissue. And then you are left with ruling out all the possibilities of a lymphoma, a carcinoma, a melanoma. How to do that? So having a basic panel of IHC markers is mandatory, at least to differentiate between these 3-4 groups. First, try to rule out all the other possibilities. It's not lymphoma, it's not carcinoma, it's not melanoma, it's not mesothelioma. it's a soft tissue tumor. And we can take help of certain parameters, like look at the lesion, but before that look at the clinical details. In the clinical details you may find two important things: the age and the location of the tumor. And based on that I would show certain examples, like if the lesion is present in a kid which is less than 3 years old, these are the differentials that you may consider, like fibrous hematoma of infancy, inclusion body fibromatosis, infantile fibrosarcoma, myofibroma, lipofibromatosis and lipoblastoma. So the blastomas, usually we know that जब भी आप blastoma सोचते हैं, usually वो pediatric एज ग्रुप का पेशेंट होना चाहिए. सो आप जब भी यू आर अप्रोचिंग अ ट्यूमर अंडर योर माइक्रोस्कोप, you should have a look on the cell type. Where should I group it? Is it a round blue cell tumor? Is it an epithelioid looking tumor? Is it a purely spindle tumor? And then put some IHC markers if you have to delineate. I'm not dealing, see, spindle cells doesn't always mean that you're dealing with a mesenchymal tumor. You can have a spindle cell squamous cell carcinoma. You can have various tumors which may have spindeloid morphology or metaplastic changes. So ruling out the mimics is mandatory and first. Then you can have a infant or children less than 20 years age where these diagnoses should be considered, like calcifying aponeurotic fibroma, Gardner fibroma, embryonal RMS, caposiform hemangioendothelioma, extrarenal rhabdoid. Then you have 10 to 35 years old. These are the differentials, including the synovial sarcoma, myxoid liposarcoma, alveolar rhabdomyosarcoma, inflammatory myofibrotic tumor and all. You can have 20 to 50 years age patient and then the differentials change. Here you have to think of a DFSP, dermatofibrosarcoma protuberans, tenosynovial giant cell tumor, leiomyosarcoma, clear cell sarcoma. So one needs to have a age based differential. हो सके तो मेरे पीजी दोस्तों अपने आसपास किसी चार्ट में, किसी पेपर में, you must put a differential diagnosis based on the age and the location. I am not telling that these are exclusive to these age groups or these locations, but they help in a large extent. There can be overlaps, there can be aberrant age groups of presentation of a tumor, but these definitely help. I'd be highlighting certain important points which the clinical or the radiological points which help in, on a great extent. More than 50 years, usually the undifferentiated pleomorphic sarcoma, myxofibrosarcoma, desmoplastic fibroblastoma, elastofibroma. So you see all the blastomas, again here I also see one blastoma present. So it's not necessary that everything fits into one basket and it doesn't go into the other. And the location wise, so if you look at the location, the trunk, shoulder, so you can divide you can also have a picture like this in your study room or in your PG classroom, where you can always look at the common locations. So diaphragm ke upar, diaphragm ke niche, intra-abdominal or acral, like limbs or the fingers or toes. So that way it will help you. For example, tumors arising from the mesentery, omentum, peritoneal fat, retroperitoneum, it will have very less number of differential diagnoses to be ruled out. So it is helping me. If I have to, if somebody tells me it is a tumor arising from the omentum, and if it is not a lipo wala tumor, so including the lipoma or liposarcoma and its different variants, I would think of a benign tumor like desmoid fibromatosis or IMT. So keeping in mind the location of the tumors and their differentials definitely helps. Two things for now: age based differentials and the location based differentials. Then we must look at the cell shape, which I have already talked. Like you are getting a long spindle cell, it may be leiomyosarcoma, it may be spindle cell rhabdomyosarcoma, or variety of things including the fibroblastic and neural tumors. If the pattern is of small, round, lymphocyte like cells, forming some certain patterns like rosettes, like having neuropils. These will give you different type of differential diagnosis to be thought of. The stroma is very important. Soft tissue tumor में जब आप cells देख रहे हो, never forget the stroma, which was also very aptly highlighted by our respected senior Professor Mandal sir. Uh, Stroma is very important, and why I will show you, because आपसे अगर मैं पूछूं कि मिक्सॉइड स्ट्रोमा होता है तो क्या ट्यूमर्स हो सकते हैं, and I think if you would start taking a variety of names, myxoid, क्या myxoid fibrosarcoma, myxoid lipo